So my name's Craig Walker. I'm one of the intensive care and A&E Reggies in Edinburgh. We're going to talk about intraosseous access. I've been joined by Simon Creve and Ian Wilson from Eden Medical, who not only are here to provide us with a bit of additional or a bit of expertise, they've also provided the equipment for you all to have a shot later on. So it's not just a chat session. So intraosseous access. I thought we'd start off by showing a little video of someone getting an IO needle in, because it's a bit of a jump to think about going suddenly putting a needle in somebody's bone. I just show you one person getting it done first. So you okay to change that over? Okay, this is the CEO of Vidacare, who make Easy IO. It's Michelle Fox. She's going to get one in a humerus. Done. Okay. So, thank you very much. So whereas you might not volunteer for it, unless you had private health insurance, like she clearly does, it's not actually something to be too afraid of doing. Okay. So, so we're going to talk about why we use it, or why you could use it, when to do it, when not to use it, and where not to use it, whereabouts in the body you should put it in. How to do it, and a little bit about the potential complications. And then after we've done with the talk, you folks are going to have a shot, all right, on the models, bony models at the back. All right. You're very welcome to try on each other, but I've not got insurance for you folks, so it's entirely at your own risk. So why are you going to do it? Well, if you can't get IV access, okay, if you need it in a hurry. You can't always get IV access when you need it quickly. All right? I'm sure you can all think of quite a few situations in which it's been very difficult to or impossible to get a line in. So, big fat people, all right, morbidly obese people who have got folds of skin on their folds of skin, and you can't see or feel a peripheral vein anywhere. IV drug users who've used up all the peripheral veins, and often their femorals, sometimes their neck veins as well. Chemotherapy patients who've had sclerosing agents go up their veins, renal patients. So if you've got a fistula in one arm, and you've got no veins, or trauma in another arm, then you're already limiting your options. And it's quite difficult to get lines in the legs. Big lymphodematous patients with big swollen arms and legs. Trauma, all right. It's difficult to put a ventral in the hand if you've not got a hand left. Going through burnt tissue, which is actually reasonably common. So diabetics are, poorly controlled diabetics. So teenagers are often very frequently in hospital, have had loads of Enflons, and it can just be difficult to try and find a vein, particularly when they're shocked and dehydrated. Children, it's hard enough putting the Enflon in a 1-year-old at the best of times if you're in a hurry. It can be impossible if they're acutely unwell, and sometimes just don't have a vein. Who advocates using them? Well, the Advanced Life Support Group advocate using them. And they came out with this guideline in 2010. So IO access is becoming established as a route of choice intraosseous access. The route of choice if IV access is not possible or associated with a delay in the first 2 minutes of resuscitation. Seems quite quick, doesn't it? That's the Advanced Life Support Group. But it certainly means that it should be something that you should be thinking about doing. We should not, hopefully, give drugs down ET tubes anymore. All right, they're ineffective, and you're putting an extra volume of fluid in the lungs. And yes, you could put a central line in, but as I'm sure you're all aware, you need someone who's able to do it, and it takes time. It's not all that quick. Okay. The Easy IO group, who make the Easy IO drill. They advocate for adults and paediatrics any time in which vascular access is difficult to obtain in emergent, urgent, or medically necessary cases. So you've got someone who's acutely, severely unwell, and you can't get a Venflon in quickly. What else are you going to do? Okay, so when not to do it. Here's a couple of things not to do. Here's when not to do IO access, or not to use an IO needle. So in patients who've got a fracture proximal to the bone that you're putting it in, okay, if you're going in the distal tibia and you've got a proximal tibial fracture, then don't do it. Obviously, if the leg or arm is partly hanging off. If the limb is black, so local ischemia. If there's infection at the site where you're going through. So if they've got infection in their bone or in their skin. So it's all obvious stuff, okay? Yeah, this one's always listed. If they've got a prosthetic limb or prosthetic joints. One of the access devices, which we'll talk a little bit, very briefly about, is called the FAST-1, which is a sternal access device. Don't use that if they've had a sternotomy and they've got wires holding their sternum together. Often people who've had bypass grafts, their sternums don't actually unite fully, so you wouldn't put it in there, obviously. And anyone who's got congenital or acquired bone abnormality. So if they've got brittle bones, osteogenesis imperfecta, then don't put it in. And if they've had another IO needle, IO cannula in the same limb in the last 24 hours, you don't want to be putting another one in for it then to come out a hole further up. Okay. So all really straightforward stuff. So how do we do it? Well, we'll have a quick chat in a few other slides about the Cook needle, which is one I'm sure probably the ones that you've practiced with. The Easy IO, which is what we'll have a shot with at the back. And then I'll just talk about the other two on this slide because we're not talking about them elsewhere. The BIG, American, is the bone injection gun. All right, it's a semi-automatic device. The way you use it, red's pediatric, adult is blue. For the pediatric one, you set the depth gauge, you just turn it, and it has an age in years. So you set it to correct depth. Adults, it's always at one depth. You hold it on the limb at the right site, which we'll talk about in a bit. And then you pull out the needle part, you pull out the red part at the top, put a little bit of pressure on the top of it, and it fires straight into the depth, which has already been set. Okay? Set the depth, or just put it on an adult, hold it firmly, pull out the top, push it in, and it fires. The FAST-1 is the one that the military often use. It was used at the Beijing Olympics, apparently. Don't have a vasovagal at the next Olympics in London. It's a sternal device. So you needle at the patient's head. There's a little dressing, which is a little landmark dressing that you put on. It's a kind of inverse triangle, which goes on the sternal notch. And then there's a hole in it, a circular hole, which shows the exact place to push that. And then you just push with a constant pressure, and it goes through the sternum. There are lots of videos on YouTube, as there always are, of various people getting them put in, various awake people who don't actually need them, big buff army guys, perhaps not our standard population, who are getting sternal ones in, so feel free to look that up. But we're going to be talking mainly about the Cook and the Easy IO needles. So where do you do it? Well, it doesn't matter which device you're using. These are the landmarks. So the proximal tibia is the one that you commonly use. So if you have a feel down your own knee, and you get the soft part, a little bit distal, just anteriorly, there's a prominence there. Go 2 centimeters medial, and there's a big flat part of bone in there. That's where we're going, all right? In kids, you can put it in, in adults, put it in at that location or 1 centimeter more proximal. In kids, we go a little bit more distal, so 1 to 2 centimeters further down. The reason for that is to keep away from the epiphysis, which is the growth plate, so you don't want to go injuring the growth of their bone in future. So tibial prominence, tibial tuberosity, go more medially, flat part of bone, put it right in there. You can go in the ankle as well. So you feel the medial malleolus, and you go 4 centimeters above, so they always say 2 finger breadths, and it's again the flat part of bone. The proximal humerus is going to be used more often. It gets into the central circulation very, very quickly. Okay? It's within a few seconds. And it's often one that people are a bit more reluctant to use. There's a couple of different ways of doing it, but the one that's advocated at the moment is you put their arm in sling position, so adducted, internally rotated. Feel off the end of the shoulder, and the bony prominence that you feel there at the top of your shoulder, the humerus, is the greater tuberosity. And you just go 90 degrees to that. Okay, and we can have a practice at the back with a few models that we've got. So how do you do it? Well, ATLS, I'm sure a few of you have done the ATLS course, practice on chicken bones, chicken legs. The Cook needle is the first one. Has anyone used the Cook needle from here? Or practiced with it? Yeah, a few of you? Okay. So you hold it in your hand like that, okay? You take the black part in the palm of your hand, you get the same landmark, and then you use a constant pressure, rotating motion back and forward. You go through the cortex, and then you feel a give, and that's you in the medullary canal, and it should just stand up straight at that point. It can take a little second to get through it, but they're the cheapest ones, and they're the ones that have been around for a while, so you may see that in a few of the resus bays that you have. Let's move on to the next one. So the EZ-IO, so used by almost all of the US advanced life support ambulance crews, more than half of all United States emergency departments, by the military, and used in Scotland. And if you have an automatic device, then it's very likely to be the EZ-IO. So how do you do it? Well, we can play at the back, but you find your landmark, clean it. There are 3 needles to choose from, which I'll talk about in the next slide, but you check your correct depth. You drill in at 90 degrees to the bone. Once it's in, you take off the inner part. You connect it up to some tubing, which you should have flushed already with some saline. And then you inject in under pressure, all right? So it's usually in a pressure bag. The depth gauge part is quite straightforward. So you've got 3 needles to choose from. The first one is a pediatric needle, okay? So it's a pink needle, it's the shortest one, it's obvious, that's what you're going to use. The second one and third one are both for adults, and it partly depends on the size of your patient and where you're going to do it, and the amount of soft tissue that you've got. So there are depth markers, which they don't project up too well on this slide, but there's black lines every 5 millimeters up it. And what we're wanting to do is, at the point where the needle is touching the cortex of the bone, you should be able to see at least one black line out with the skin. Okay? So you should have at least 5 millimeters out with that. Reason being that if you've got less and you start drilling, you're just going to go partly into the cortex, but not all the way through. So in the distal tibia, you're generally going to be using the smallest adult one, so the blue one. In the humerus, big, muscly people, you might be using the larger one. But all you need to remember is at least one black line being visible outside the skin when you start, okay? Once you're touching the bone part. So does it hurt? Well, it didn't particularly hurt Michelle Fox there, but then Michelle Fox has a vested interest. She is not, we don't even know if she was pre-medicated before she did that. There's been a few studies. Pain score 5 out of 10 in people who had it done on the visual analog scale, in the first one of a few hundred patients. And the second one, an EZ-IO study, they looked at 125 patients. The pain score was 1.2 out of 5 when they averaged them. Now, whether we should use lignocaine or not is something that's been debated. In an awake patient, you should think about it. So you can give a bit of lignocaine subcut, so even just 1 mil, 1%. And once you've got the IO device in, some patients, not all, find that the infusion can be a little bit sore. It can be quite painful. They advocate using about 50 milligrams of lignocaine, so 2.5 mils, 2%, or 5 mils, 1%, just as a slow flush to get things started. Okay. And when the EZ-IO